Hello, this is a brief talk about our review article Rule of Trapezius Transfer for Shoulder Reconstruction in Adult Traumatic Brachial Plexus Injuries. Shoulder function is affected in all brachial plexus injuries except in lower trunk palsy, and even with functioning elbow, wrist, and fingers, upper limb function is significantly hampered by deficient shoulder function. The aim of surgery for shoulder reconstruction is to get stable shoulder with good range of motion. Primary nerve reconstruction is considered the gold standard method. It includes direct coaptation, neurolysis, nerve graft, and nerve transfer. If surgery is early and successful, adequate reinnervation of deltoid, teres minor, supraspinatus, and infraspinatus muscles can be achieved. While secondary reconstruction options for shoulder include fusion, muscle or tendon transfer, those options are indicated in neglected cases that are presented more than 1 year after injury without any attempt for reconstruction, and cases of complete or partial failure of recovery of both deltoid and rotator cuff after primary reconstruction. To understand the basic principles of shoulder reconstruction after brachial plexus injury, we should understand the shoulder kinematics. Shoulder joint is unique in that it has the widest range of motion, and it is the least stable joint in the body. The range of motion is achieved by the scapulohumeral rhythm, which is coordinated motion of glenohumeral, scapulothoracic, acromioclavicular, and sternoclavicular joints. The rotator cuff muscles are primary dynamic stabilizers for shoulder during abduction, forward reflection, and extension that act by resisting the relative upward shearing movement at the glenohumeral joint by the deltoid in early abduction, and through a force couple of suprascapularis anteriorly and infraspinatus posteriorly. Nerve blocks of the infraspinatus lead to 45% loss of the abduction strength and 70% loss of external rotation strength. Paralysis of both supraspinatus and infraspinatus lead to decrease in abduction strength by 75% and decrease in external rotation strength by 80%. The teres minor play a role in external rotation strength at any angle of shoulder abduction less than 20%. These relations explain why isolated trapezius transfer alone lead to an obligatory proximal migration of humeral head, narrowing of the space between the humeral head and the acromion, which causes mechanical impingement and decreases the trapezius lever arm, leading to ineffective shoulder abduction and deflection. The basic principles of tendon transfer are difficult to apply to the shoulder due to complex polyaxial shoulder motion, but they should be considered in performing shoulder tendon transfer. And this table shows the excursion and tension of shoulder muscles and possible muscles for transfer. For deltoid and rotator cuff, they have low excursion and high tension. For upper trapezius, it has superior excursion and low tension. For latissimus dorsi, it has high excursion and low tension. Primary nerve reconstruction for gaining shoulder function, it includes neurotizing the suprascapular and or axillary nerve. The donor nerves for neurotization include spinal accessory nerve, phrenic nerve, intercostal nerves, cross-neck C7, thoracodorsal nerve, radial nerve branch to long head of triceps, medial pectoral nerve, hypoglossal nerve. The balance between the available donor and the required recipient for nerve transfer in upper trunk palsy increase the ease of neurotizing both suprascapular and axillary nerves and achieving the best results. However, in more extensive injury, especially global avulsion in palsy, this balance is much more difficult to achieve, and maximum of one nerve transfer can be done for the shoulder. This situation gives rise to the question of whether the results of second reconstruction procedures, including fusion and trapezius transfer, are comparable to the results of single nerve transfer for the shoulder. If the answer is yes, the badly needed extraplexal donor nerves can be saved for the other recipient or for free functioning muscle transfer innervation later on. For second shoulder reconstruction, the first option includes shoulder fusion. the shoulder fusion is indicated in inferior subluxation reduction and for improving chronic shoulder pain. However, the main drawback is the shoulder motion completely dependent on scapulothoracic motion, which is deficient in many patients with brachial plexus injuries, and also hindered self-hygiene and irreversibility of the fusion, and high incidence of fracture should be considered. That's why you have to keep the fusion as the last option for shoulder if no donor nerves for primary reconstruction or donor muscles for secondary reconstruction are available. Some recent modification for the technique of the shoulder fusion has been showing better results. That's why it has been reported in literature. The first technical modification for shoulder fusion include acromial osteotomy, in which you osteotomize the acromion and prepare the acromiohumeral surface for fusion in addition to the glenohumeral surface, which increase the fusion surface area and provide better contouring for the plate bending. And the second modification is double blading. This drawing is showing acromial osteotomy technique for shoulder fusion. The second option for shoulder reconstruction is a muscle transfer. The difficulties in muscle transfer is that the shoulder joint is polyaxial joint and there are few functioning muscles are available due to affection of the muscle supplied by the injured brachial plexus. Their expandability is unclear and difficult strength determination because of the complex interaction of the force and shoulder girdle. Donor muscles available for transfer include trapezius, latissimus dorsi and/or teres major, pectoralis major, levator scapulae, long head of biceps and triceps, pedicle latissimus dorsi. To start talking about our topic in more detail, trapezius has been used as a donor muscle for muscle transfer for shoulder reconstruction, as being supplied by a spinal accessory nerve besides contribution from C3 and C4, so it is spared even in total brachial plexus injury. Trapezius transfer is indicated in shoulder instability and or deficient abduction or forward deflection, and when there is no improvement in shoulder function obtained after primary nerve reconstruction or intensive conservative therapy. The criteria for performing trapezius transfer are that the trapezius muscle must show full strength against resistance, passive shoulder abduction at least 80 degrees before preoperative. The surgical technique for trapezius transfer, it includes upper trapezius transfer, which has been first described by Hoffa in 1891, but the main drawback of this technique is shortage of tendon to reach the deltoid, and even elongation by fasciolateral graft led to stretch and scarring and subsequent poor results. So they started to modify the technique to get much more better results, and Batman modification in 1955 by transfer the trapezius acromial insertion to proximal end of the humerus. However, shortage of the lever arm of the transferred trapezius was still an issue. Another modification by Saha in 1967, he provided a more distal fixation of the transfer just distal to the greater tuberosity after more proximal release, providing a greater lever arm. Additionally, osteotomizing the acromion allowed to better fixation to the narrow cylindrical shaft of the humerus. Fixation was provided by two 6.5 mm cancellous screws with the shoulder positioned in abduction from 80 to 90 degrees, and since that time, Saha's name has been associated with that type of operation. Last modification done by Rahman. At first, Rahman used Saha's technique, then he modified the method by suturing the partially free deltoid muscle under maximum tension on the top of the trapezius as far as medially as possible. Therefore, the trapezius power act on the humerus along the deltoid insertion area. He reported significant improvement in outcome with this modification. This drawing is showing fixation of transferred trapezius with its acromial attachment to the proximal humerus as described by Saha. And this drawing is showing suturing of the deltoid over transferred trapezius as described by Rahman. Another technique for trapezius transfer is lower trapezius transfer, which is originally described by Al-Hassan. At first, for lower trapezius transfer, prolongation of the lower trapezius with a tendon allograft was used to transfer the lower trapezius to the infraspinatus. Then he modified his technique with direct transfer of the lower trapezius tendon to the infraspinatus tendon without using a graft. Two incisions were used, the first being 2 cm medial to the scapula to harvest the lower trapezius and separate it from the middle trapezius while protecting the spinal accessory nerve, and the second incision being lateral to expose the infraspinatus tendon and peel off the muscle fibers to obtain approximately 7 cm length of the tendon, which make the direct transfer possible without a graft. A deep subcutaneous tunnel between the medial and lateral incision is used to pass the lower trapezius tendon to the infraspinatus tendon, and tensioning is performed in full external rotation. However, the main drawback of this technique is it is not possible in all patients, especially those who underwent primary nerve reconstruction, and spinal accessory nerve has been used as a donor nerve in neurotization. This drawing showing medial incision to harvest the lower trapezius through medial incision, and this one is showing passage of the lower trapezius tendon through subcutaneous tunnel from medial to lateral to be transferred and sutured to infraspinatus tendon. This table is summarizing the results of trapezius transfer as reported in literature. This study included 27 patients, 5 of them were complete brachial plexus palsy, 16 were upper trunk palsy, 6 were upper and middle trunk palsy. He used SAHS technique. The mean preoperative shoulder abduction was 4 degrees. The mean postoperative shoulder abduction was 45 degrees. Cotwell study included 26 patients. 8 of them were brachial plexus and 18 were post-poliomyelitis. He used SAHS technique. He didn't mention the preoperative shoulder abduction, while the postoperative shoulder abduction was 46 degrees. Merbel study included 6 patients of brachial plexus. He used SAHS technique, and the mean preoperative shoulder abduction was 13 degrees, while the mean postoperative shoulder abduction was 76 degrees. The Montreal study included 10 patients. 6 of them were upper trunk. 1 case was upper and middle. 3 cases were complete palsy. He used SAHS technique, and the mean preoperative shoulder abduction was 3.1 degree. The mean postoperative shoulder abduction was 50 degree. Rahman study included 80 patients. 37 cases were complete palsy, and 43 cases were partial brachial plexus injury. He used SAHS technique in 58 patients, and he used his own modification in 22 cases. The mean preoperative shoulder abduction was 6 degrees, and the mean postoperative shoulder abduction was 34 degrees, and there is no change in external rotation either pre or post-operative. Al-Hassan study included 52 patients. 13 of them were complete palsy, 12 of them were upper trunk, 22 were upper and middle trunk, 5 of them were C5, 6, 7, 8 root in palsy. He did lower trapezius to infraspinatus in all cases, and he used Rahman modification in 39 cases. The preoperative shoulder abduction was 10 degrees, and postoperative shoulder abduction was 50 degrees. The external rotation gained after surgery was 20 degrees. Bertilli study included 7 patients. 3 of them were upper trunk and 4 of them were upper and middle. He used lower trapezius transfer to infraspinatus and Rahman modification in all cases. The preoperative shoulder abduction was 0. The postoperative shoulder abduction was 38, and the patient gained mean 104 degree external rotation from full internal rotation position. So finally, to conclude, the primary nerve reconstruction remains the gold standard method for reconstruction of brachial plexus injury. Late presented and failed cases still have a secondary chance of reconstruction. Rahman modification of SAHS technique with acromial osteotomy fixation as distal as possible and tensioning of deltoid closure has achieved improved outcome in terms of stability and abduction recovery. Using upper and lower trapezius for possible restoration of abduction external rotation as described by Al-Hassan showed a mean post-operative shoulder abduction and external rotation of approximately 50 and 20 degrees respectively.